Welcome to the Path Podcast. I'm Shafir Ahmad, your host, with new exciting episode. So stay tuned in. Please follow me on YouTube, Twitter, and Instagram with the handle bar at Shafir Ahmad 4109. And please feel free to share these chunks of knowledge. Thank you. Today, the topic of discussion of our podcast is Neoplasms of Thyroid. So first of all, we will discuss about histology of the thyroid gland, that what is basically thyroid gland composed of. So at the microscopic level, there are three primary features of the thyroid. One, thyroid follicles surrounded by thyroid follicular cells and parafollicular cells. So thyroid is basically comprised of thyroid follicles, thyroid follicular cells, and parafollicular cells. So follicles. Thyroid follicles are small spherical openings of cell round about like 0.02 to 0.9 millimeter in diameter that play the main role in thyroid function. They consist of a rim that has a rich blood supply, nerve and lymphatic presence that surrounds a core of colloid that consists mostly of the thyroid hormone precursor proteins called thyroglobulin and iodinated glycoprotein. So, colloid consists of thyroid hormone precursor protein called thyroglobulin and iodinated glycoprotein. So, this is an important concept to understand. So, let us briefly discuss that what colloid is all about. So colloid is a mixture in which one substance consisting of a macroscopically dispersed insoluble particles is suspended throughout another substance. So this colloid concept is important in the thyroid because we have to understand that yes, what basically colloid consists of and what the function of thyroglobulin is, which we will discuss shortly. Then the follicular cells. The core of a follicle is surrounded by a single layer of follicular cells, and when stimulated by thyroid stimulating hormone, these secrete thyroid hormone T3 and T4. And they do this by transporting and metabolizing the thyroglobulin contained in the colloid. So the thyroglobulin containing the colloid will be transported into these follicular cells, and then T3 and T4 will be secreted. So follicular cells vary in shape from flat to cuboidal to columnar, and depending upon how active they are, so they will have their shapes. Then the follicular lumen. The follicular lumen is the fluid filled space within a follicle of the thyroid gland. So within the follicle there is a fluid filled space, and that is known as follicular lumen. So there are hundreds of follicles within the thyroid gland. A follicle is formed by a spherical arrangement of follicular cells, and the follicular lumen is filled with colloid, which is, we will discuss again that it's a concentrated solution of thyroglobulin and is the site of synthesis of the thyroid hormone thyroxine and triiodothyronine. So thyroxine is basically T4 and triiodothyronine is T3. And then there are the parafollicular cells. They are scattered among follicular cells, and in spaces between spherical follicles are another type of thyroid cells that are known as parafollicular cells. And what they secrete is that is known as calcitonin, and that's why they are also known as C cells. So let us briefly discuss about that how the thyroid hormone is produced, because this is relevant to our discussion of the neoplasms of thyroid. So the thyroid hormones are created from thyroglobulin, as discussed previously, that inside the colloid there is thyroglobulin. So this is the protein within the colloid in the follicular lumen that is originally created within the rough endoplasmic reticulum of follicular cells. And then what happens that it is transported into the follicular lumen. So then thyroglobulin contains like 123 units of tyrosine which reacts with iodine within the follicular lumen. So iodine is essential for the production of the thyroid hormones, and iodine travels in the blood as iodide, which is taken up by the follicular cells by sodium iodide symporter. And this is an ion channel on the cell membrane which in the same action transports two sodium ions and an iodide ion into the cell. So what happens is that iodide then travels from within the cell into the lumen through the action of pendrine, that is an iodide chloride antiporter. So in the follicular lumen, the iodide is then oxidized to iodine, and this makes it more reactive. And the iodine is attached to the active tyrosine units in the thyroglobulin by the enzyme thyroid peroxidase. So this enzymatic reaction forms the precursors of thyroid hormone, which are known as MIT and DIT, and MIT stands for monoiodotyrosine and DIT stands for diiodotyrosine. So when follicular cells are stimulated by thyroid stimulating hormone, the follicular cells reabsorb thyroglobulin from the follicular lumen, and the iodinated tyrosines are cleaved, forming the thyroid hormones T4, T3, DIT, MIT, and some traces of reverse triiodothyronine. T3 and T4 are released into the blood. The hormones secreted from the gland are about 80 to 90% of T4 and about 10 to 20% of T3. So what happens that deiodinase enzymes in the peripheral tissues remove the iodine from MIT and DIT and convert T4 to T3 and reverse T3. And this is the major source of both RT3 and T3 in the peripheral tissues. So this is the little bit introduction about the histology and slightly bit of physiology. So now we will discuss about the neoplasms of the thyroid after understanding the basic structure of the thyroid and basic function of the thyroid. So the thyroid gland gives rise to a variety of neoplasms ranging from circumscribed benign adenomas to highly aggressive anaplastic carcinomas. So from a clinical standpoint, the possibility of a tumor is of major concern in a patient who presents with thyroid nodule. So fortunately, the overwhelming majority of solitary nodules of the thyroid are proved to be either follicular adenomas or localized non-neoplastic conditions like dominant nodule in multinodular goiter, simple cysts, or foci of thyroiditis. So carcinomas of the thyroid, by contrast, are uncommon, accounting for much less than 1% of solitary thyroid nodules. So several clinical criteria provide a clue to the nature of a thyroid nodule. So if the nodule is solitary, so in general are more likely to be neoplastic than multiple nodules. So these are basically just general criteria to just give a clue that whether the patient is having neoplasm or not. But of course, this is not like hard and fast rule that yes, if the patient is having solitary nodules, so the patient must be having thyroid glands, because we have to go for the procedure step by step for the diagnostic accuracy. So solitary nodules in general are more likely to be neoplastic than are multiple nodules. Then nodules in the young patient are more likely to be neoplastic than those in the older patients. Nodules in males are more likely to be neoplastic than those are in females. A history of radiation treatment to the head and neck region is associated with increased incidence of thyroid malignancy. Nodules that take up radioactive iodine in imaging studies, also known as the hot or functioning nodules, are more likely to be benign than malignant, and basically they are reflecting the well differentiated cells. So, such statistics and journal trends, however, of little significance in the evaluation of a given patient in whom the timely recognition of a malignancy, however uncommon, can be life saving. So, ultimately, it is the morphologic evaluation of a given thyroid nodule by a fine needle aspiration combined with histological studies of the surgically resected specimen of the thyroid parenchyma that will provide the most definitive diagnosis about the nature of any insult to the thyroid. So, let us start by discussing the adenomas. So, adenomas of the thyroid are benign neoplasms derived from follicular epithelium. Now, as in the case of all thyroid neoplasms, follicular adenomas usually are solitary. So, on clinical and morphological grounds, they may be difficult to distinguish from a dominant nodule in a multinodular goiter, for example, or from less common follicular carcinomas. So, we have to take care of whether this is an adenoma or it's an isolated, uh, you can say, dominant nodule in, for example, multinodular goiter, or it can be follicular carcinoma. So we will distinguish that how we will do the distinguish between all this stuff. So although the vast majority of adenomas are non-functional, a small portion produce thyroid hormones and also known as toxic adenomas and cause clinically apparent thyrotoxicosis because of increased level of thyroid hormones. So in general, follicular adenomas are not forerunners to carcinomas. Nevertheless, they share genetic alteration that support the possibility that at least a subset of follicular carcinomas arise in the pre-existing adenomas. So let us see that now what is the pathogenesis of this adenoma, that how this adenoma emerges out, and then when we will discuss the carcinomas, so we will understand the pathogenesis of the carcinomas, and we will come to know that there are some sort of similarities in the genetic makeup of adenomas and carcinomas. So the TSH receptor signaling pathways plays an important role in the pathogenesis of toxic adenomas. So activating somatic mutations. So it is a somatic mutation, and what sort of mutation it will be? It will be a gain of function mutation in one of the two components of this signaling system. So most often the gene encoding the TSH receptor itself, and less commonly the alpha subunit of G stimulatory protein, gene S. So they allow the follicular cells to secrete thyroid hormone independent of TSH stimulation. So what will happen, that there will be the autonomy of the thyroid gland, and it will start secreting the thyroid hormone without any sort of TSH stimulation. So the result of this overabundance is a symptomatic hyperthyroid state with a hot thyroid nodule seen on imaging studies. So overall, somatic mutations in the TSH receptor signaling pathways seem to be present in slightly over half of the toxic adenomas. So not surprisingly, such mutations also are observed in the subset of autonomous nodules that give rise to the toxic multinodular goiters. So a minority of non-functioning follicular adenomas, like less than 20%, exhibit mutations of RAS or phosphatidyl and isotyl 3 kinase, which is also known as PIK3CA, or possess a PAX8/PPARG fusion gene, all of which are genetic alterations shared with the follicular carcinomas. So follicular carcinoma genetics we will discuss shortly. So the typical thyroid adenoma on morphology is solitary, having spherical lesion that compress the adjacent non-neoplastic thyroid. So the neoplastic cells are demarcated from the adjacent parenchyma by a well-defined intact capsule. So again I am repeating that the thyroid adenoma has to having the intact capsule, and it usually compresses the adjacent non-neoplastic thyroid. Because these features are important in making the distinction from multinodular goiter, which contains multiple nodules on their cut surface, and they will not demonstrate compression of the adjacent thyroid parenchyma and also lack a well-formed capsule. So, on cut section, multinodular goiter will have multiple nodules, but the patient may present clinically with a solitary dominant nodule only. So that is why it is important to distinguish thyroid adenomas versus these multinodular goiters. So on microscopic examination, the constituent cells are arranged in uniform follicles that contain colloid and papillary growth patterns, if present, should raise suspicion for an encapsulated papillary carcinoma. So papillary means finger-like projections are present, so then you will have to suspect that it might be a papillary carcinoma, which we will discuss shortly. So on histology, occasionally the neoplastic cells acquire brightly eosinophilic granular cytoplasm, also known as Hürthle cell change or oxyphil. So the clinical presentation and behavior of Hürthle cell adenoma are no different than from the conventional adenomas, only the difference in the histology. So similar to endocrine tumors at other anatomic sites, even benign follicular adenoma may on occasion exhibit focal nuclear pleomorphism, atypia, and prominent nuclei. This all points like nuclear pleomorphism, atypia, and prominent nuclei are also known as endocrine atypia. So by themselves, these features do not constitute evidence of malignancies. So the hallmark of all follicular adenomas is the presence of an intact, well-formed capsule encircling the tumors. Again, I am repeating this. So therefore, careful evaluation of the integrity of the capsule is therefore critical in distinguishing thyroid, these follicular adenomas from the follicular carcinoma, which demonstrate capsular or vascular invasion. So therefore, this examination of capsule becomes very important to distinguish follicular adenomas versus the follicular carcinomas, because when there is carcinomas, so definitely we have to expect some sort of invasion. So clinically, most adenomas of the thyroid manifest as painless nodules, often discovered during a routine physical examination. Larger masses may produce local symptoms such as difficulty in swallowing. So toxic adenoma, when there will be toxic adenoma, so there will be T3 and T4 in surge, so there will be symptoms of thyrotoxicosis. So after injection of the radioactive iodine, most adenomas take up iodine less avidly than the normal thyroid parenchyma. So on radionuclide scanning, therefore adenomas appear as cold nodules relative to the adjacent normal thyroid gland. But the toxic adenomas, as we have discussed previously, will produce the symptoms of thyrotoxicosis because of increased secretion of thyroid glands, will appear as warm or hot nodules in the skin. So as many as 10% of the cold nodules eventually prove to be malignant. By contrast, malignancy is rare in the hot nodules. So essential techniques used in the preoperative evaluation of the suspected adenomas are ultrasonography and fine needle aspiration biopsy. So because of the need for evaluating capsular integrity, the definitive diagnosis of thyroid adenoma can be made only after careful histologic examination of the dissected specimen. So suspected adenomas of the thyroid are therefore surgically removed to evaluate, and then on histopathology they will see that whether there is malignancy or not. So therefore it is important to exclude malignancy. So thyroid adenomas generally carry an excellent prognosis, and recurrence is not common, and even though they also don't metastasize. So now we will discuss the carcinomas of the thyroid gland. So they are relatively uncommon in the United States, accounting for about 1.5% of all cancers. So, female predominance has been noted among patients who develop thyroid carcinoma in the early and middle adult years. By contrast, cases manifesting in childhood and late adult life are distributed equally between males and females. So, most thyroid carcinomas are derived from thyroid follicular epithelium, and of those, the vast majority are well differentiated lesions. So, the only exception is the medullary carcinoma, which is not derived from the thyroid follicular epithelium cells but are derived from parafollicular or C cells. So, the major subtypes of the thyroid carcinoma and their relative frequencies are papillary carcinoma. The second is the follicular carcinoma. The third is anaplastic, and the fourth is the medullary carcinoma. So, papillary carcinoma accounts for like about 85% of the cases. Follicular carcinoma is in between the range of 5% to 15% of the cases, and anaplastic carcinoma is like less than 5% of the cases. And medullary carcinoma is also around in that margin of 5% of the cases. So, because of the unique clinical and biological features associated with each variant of thyroid carcinoma, these subtypes we will describe separately one by one in detail of their morphology and the clinical features. But first of all, we will discuss the pathogenesis of all the thyroid cancers. Both genetic and environmental factors are implicated in the pathogenesis of the thyroid cancers. Now, distinct molecular events are involved in the pathogenesis of the four major variants of the thyroid cancer. So, as previously discussed, that medullary carcinomas do not arise from the follicular epithelium. Genetic alterations in the three follicular cell-derived malignancies are clustered along two oncogenic pathways. One is the mitogen activated protein MAP kinase pathway, and the second one is the phosphatidyl and inositol 3 kinase PI3K/AKT pathway. In normal cells, these pathways are transiently activated by binding of soluble growth factor ligands to the extracellular domain of the receptor tyrosine kinases, which results in the autophosphorylation of the cytoplasmic domain of the receptor, permitting the intracellular cell transduction. In thyroid carcinoma, as with other solid cancers, gain of function mutation along the component of these pathways lead to constitutive activation even in the absence of the ligand, thus promote the carcinogenesis. So it means that the ligand will not be needed for the receptor activation, and a receptor will become immortal, and it will, like after gaining function of mutation, it will just start working without any sort of ligand on its own autonomously. So papillary thyroid carcinomas, so activation of the MAP kinase pathway is the classical feature of most papillary carcinomas and can occur by one of two major mechanisms. The first mechanism involves rearrangement of RET or NTRK1. NTRK1 is neurotrophic tyrosine kinase receptor 1, and both of which encode transmembrane receptor tyrosine kinases. And the second mechanism involves activation point mutations in BRAF, whose product is an intermediate signaling component in the MAP kinase pathway. So the RET gene is not normally expressed in thyroid follicular cells. In papillary cancers, chromosomal rearrangements place the tyrosine kinase domain of the RET under transcriptional control of genes that are constitutively expressed in the thyroid epithelium. So the novel fusion proteins that are so formed are known as RET/PTC. PTC stands for papillary thyroid carcinoma and are present in approximately 20% to 40% of the papillary thyroid cancers. The frequency of RET/PTC rearrangement is significantly higher in papillary cancers arising in the backdrop of the radiation exposure. That's why radiation exposure and papillary cancers are having a correlation with each other. So similarly, rearrangements of NTRK1 are present in 5% to 10% of the papillary thyroid cancers, and the resultant fusion proteins are constitutively expressed in the thyroid cells, leading to activation of MAP kinase pathway. So, one third to one half of the papillary thyroid carcinomas harbor a gain of function mutation in the BRAF gene, which most commonly is valine to glutamate change on codon 600, also known as BRAF V600E. So, since chromosomal rearrangements of RET or anti-RK1 genes and the mutations of BRAF have redundant effects on the thyroid epithelium, papillary thyroid carcinomas demonstrate either one of the other molecular abnormality but not both. And RET PTC rearrangements and the BRAF point mutations are not observed in the follicular adenomas or the carcinomas. Then is the follicular thyroid carcinoma. So, follicular thyroid carcinoma, approximately one third to one half of the follicular thyroid carcinoma possess mutation in the PI3K/AKT signaling pathways, resulting in constitutive activation of this oncogenic pathway. This subset of tumors include those with gain of function point mutations of RAS and PIK3CA, those with amplification of PIK3CA, and those with loss of function mutations of PTEN, which is a tumor suppressor gene and negative regulator of this pathway. So, the progressive increase in the prevalence of RAS and PIK3CA mutations from benign follicular adenomas to follicular carcinoma to anaplastic carcinoma suggests a shared histogenesis and molecular evolution among these follicular cell-derived tumors. So, a unique 2:3 Q13:P25 translocation has been described in one third to one half of the follicular carcinomas. This translocation creates the fusion gene composed of portions of PAX8, a paired homeobox gene that is important in the thyroid development, and the peroxisome proliferation activator receptor gene PPARG, whose gene product is the nuclear hormone receptor implicated in the terminal differentiation of the cell. So, less than 10% of the follicular adenomas harbor PAX8/PPARG fusion genes, and thus for these have not been documented in the other thyroid neoplasms. And then when it comes to the anaplastic carcinomas, so they are highly aggressive and lethal tumors, can arise de novo or more commonly by the process known as dedifferentiation. So, what is dedifferentiation? We will now briefly discuss that what dedifferentiation is all about. So, dedifferentiation is a transient process by which cells become less specialized and return to an earlier cell state within the same cell lineage. So, anaplastic carcinoma either arise de novo or from the dedifferentiation of differentiated papillary or the follicular carcinoma. So, molecular alteration present in the anaplastic carcinoma include those also seen in well-differentiated carcinomas, for example, RAS or PIK3CA mutations, but at a significantly higher rate, suggesting that the presence of these mutations might predispose existing thyroid neoplasms to transform. So, other genetic hits such as inactivation of p53 are essentially restricted to anaplastic carcinoma and may also relate to their aggressive behavior. Now, when we will see the medullary thyroid carcinomas, so these neoplasms arise from the parafollicular C cells rather than the follicular epithelium, and the familiar medullary thyroid carcinomas occur in the multiple endocrine neoplasia type 2 and are associated with the germline RET proto-oncogene mutation that lead to constitutive activation of the receptor. So, RET mutations are also seen in approximately one half of the non-familiar or the sporadic medullary thyroid cancers. So, chromosomal rearrangements involving RET, such as RET/PTC translocations reported in the papillary cancers, are not seen in the medullary thyroid carcinomas. So, the major risk factors predisposing to thyroid cancer is exposure to the ionizing radiation, particularly during the first 2 decades of life. And in keeping with this finding, there was a marked increase in the incidence of the papillary carcinomas among children exposed to ionizing radiation after Chernobyl nuclear disaster in 1986. So deficiency of dietary iodine and by extension in association with goiter is linked with higher frequency of the follicular carcinomas. Now, papillary carcinomas represent the most common form of the thyroid cancer, and these tumors may occur at any age, and they account for the vast majority of the thyroid carcinoma associated with previous exposure to the ionizing radiations. So, the clinical features of the papillary carcinomas are like that papillary carcinomas are non-functional tumors, so they manifest most often as a painless mass in the neck, either within the thyroid or as a metastasis in the cervical lymph node. A preoperative diagnosis usually can be established by fine needle aspiration on the basis of the characteristic nuclear features, which we will discuss shortly in the morphology, that what sort of nuclear features are necessary for establishing the diagnosis. So papillary carcinomas are indolent lesions like grow slowly and gradually with a 10-year survival rates in excess of 95%. So of interest, the presence of the isolated cervical nodal metastasis does not seem to have a significant influence on the generally good prognosis of these lesions. In a minority of patients, hematogenous metastases are present at the time of diagnosis, most commonly to the lung. The long-term survival of patients with papillary thyroid cancer is dependent on several factors including age. In general, the prognosis is less favorable among patients older than 40 years, and the presence of extrathyroidal extension and presence of distant metastasis, usually by during the stage of the cancer. So if we can see the morphology of the papillary carcinoma, so they manifest as solitary or multifocal lesion within the thyroid gland, and in some cases they may be well circumscribed and even encapsulated. In other instances, they infiltrate the adjacent parenchyma with ill-defined margins. The lesions may contain areas of fibrosis and calcification and often are cystic. On cut surface, they may appear granular and sometimes contain grossly discernible papillary foci. So the definitive diagnosis of papillary carcinoma can be made only after microscopic examination. Now, the important point is that in the current practice, the diagnosis of the papillary carcinoma is based on the nuclear features, even in the absence of finger-like papillary architecture. So the diagnosis of the papillary carcinoma is based on nuclear features, even in the absence of the classical presentation of the papillary architecture. So the nuclei of the papillary carcinoma cell contains very finely dispersed chromatin, which imparts an optically clear appearance, giving rise to the designation ground glass or orphan Annie nuclei. So for all of those who want to know more about the orphan Annie nuclei, so it's let us discuss about what was basically the Little Orphan Annie. So it was a daily American comic strip created by Harold Gray and syndicated by the Tribune Media Services. So the strip took its name from the 1885 poem Little Orphan Annie by James Whitcomb, and it made its debut on August 5, 1924 in the New York Daily Times. So if you Google the image of the eyes of the orphan Annie, so you will see that hollow eye without the presence of the eyeball. So it's like sort of funny character in a sense that there was eye, but there was no eye globe within, and there was only whitish color of that eye. So similarly, based upon orphan Annie comic character, they have given the name the orphan Annie nuclei to the papillary carcinoma, because you will see a clear appearance or a ground glass appearance. So you will not find anything else because the chromatin is dispersed, so that's why it will give that optically clear appearance. So in addition of the cytoplasm may give the appearance of the intranuclear inclusions, so hence the designation pseudo inclusions in cross section is also given. So papillary architecture is common. Unlike hyperplastic papillary lesions seen in the grave disease, the neoplastic papillae have dense fibrovascular cores. So another thing that is that the concentrically calcified structure termed somoma bodies often are present within the papillae. So foci of lymphatic permeation by tumor cells are often present, but invasion of blood vessels is relatively uncommon, particularly in the smaller lesions. Metastasis to adjacent cervical lymph nodes are estimated to occur in about half of the cases, and there are over a dozen variants of the papillary thyroid carcinoma, but the most common is one composed predominantly and exclusively of follicles, also known as the follicular variant of the papillary thyroid carcinoma. The follicular variant more frequently is encapsulated and is associated with the lower incidence of the lymph node metastasis and extrathyroidal extension than that of the typical for conventional papillary carcinomas. So after discussing the papillary carcinoma, let us jump to the follicular carcinoma. So follicular carcinomas account for 5% to 15% of the primary thyroid cancers. They are more common in women, occurring in the ratio like 3:1, 3 in women, 1 in man, and manifest at an older age than that of for typical for the papillary carcinomas. The peak incidence of the follicular carcinoma is between ages of 40 and 60 years. And follicular carcinoma is more important in areas with dietary iodine deficiency, while its incidence has either decreased or remained stable in iodine sufficient areas of the world. So the clinical features of the follicular carcinomas are like that they most frequently present as a solitary cold thyroid nodules, and in rare cases they may be hyperfunctioning, and this neoplasm tends to metastasize through the bloodstream, also known as hematogenous spread, to lungs, bone, and liver. So they will use the bloodstream for the spread. And in contrast with the papillary carcinomas, regional nodal metastases are uncommon. So as many as half of the patients with widely invasive carcinoma succumb to their disease within the 10 years, while less than 10% of patients with minimally invasive follicular carcinoma die within the same time span. So follicular carcinomas are treated with surgical excision. Well differentiated metastases may take up radioactive iodine, which can be used to identify and also ablate such lesions. Now, because better differentiated lesions may be stimulated by TSH, patients usually are placed on thyroid hormone regimens after surgery to suppress the production of the endogenous TSH. On microscopic examination, most follicular carcinomas are composed of fairly uniform cells forming small follicles, reminiscent of normal thyroid, and in other cases, follicular differentiation may be less apparent. Now, as with follicular adenomas, Hürthle cell variants of follicular carcinoma may also be seen, and follicular carcinoma may be widely invasive, infiltrating the thyroid parenchyma and extrathyroidal soft tissues, or it can be minimally invasive. So the minimally invasive are sharply demarcated lesions that may be impossible to distinguish from follicular adenomas or on gross examination. And this distinction requires extensive histologic sampling of the tumor capsule thyroid interface to exclude capsular and or vascular invasion. So as we have discussed before, that follicular lesions in which the nuclear features are typical of papillary carcinoma should be regarded as follicular variants of papillary cancers. Now the anaplastic carcinoma. So anaplastic carcinomas are undifferentiated tumors of the thyroid follicular epithelium, accounting for less than 5% of thyroid tumors. They are aggressive with a mortality rate approaching almost 100%, and patients with anaplastic carcinoma are older than those with other types of thyroid cancer, with a mean age of 65 years. Approximately a quarter of patients with anaplastic thyroid carcinoma have a past history of well differentiated thyroid carcinoma, and another quarter harbor a concurrent well differentiated tumor in the resected specimen. Clinically, they grow with a wild abundant despite therapy, like they will grow grow too much, and even despite of therapy they will keep on growing, and metastasis to distant sites are common, but in most cases death occurs in less than 1 year as a result of aggressive local growth and compromise of vital structures in the neck. So if you see the morphology of the anaplastic carcinoma, so they usually manifest as bulky masses that typically grow rapidly beyond the thyroid capsule into the adjacent neck structures. On microscopic examination, these neoplasms are composed of highly anaplastic cells which may take one of any of the several histologic patterns, including those populated by large pleomorphic joint cells, spindle cells with sarcomatous appearance. So, spindle cells, just like smooth muscle cells, and sarcomatous is basically just like the sarcoma. Sarcomatous is basically an adjective for the sarcoma. So, just like sarcoma, they will appear, or there will be the mixed spindle and joint cell lesions. Foci of papillary on follicular differentiation may be present in some tumors, suggesting origin from a better differentiated carcinoma. And lastly, we will discuss about the medullary carcinoma. So, medullary carcinoma isn't derived from the follicular epithelium, and they are derived basically from the parafollicular cells, also known as C cells of the thyroid. So, like normal cells, medullary carcinomas secrete calcitonin, the measurement of which plays an important role in the diagnosis and post-operative follow-up evaluation of patients. In some cases, the tumor cells elaborate other polypeptide hormones such as somatostatin, serotonin, and vasoactive intestinal peptide, also known as VIP. So, medullary carcinomas arise sporadically in 70% of the cases, and the remaining 30% are familial cases occurring in the setting of MEN syndromes, like we all know MEN 2A and MEN 2B, or familial medullary thyroid carcinoma without an associated MEN syndrome. So, of note that both familial and sporadic medullary forms demonstrate activating RET mutations, and sporadic medullary carcinoma as well as familial cases without an associated MEN syndrome occur in adults with a peak incidence in the 5th and 6th decade of the life, and cases associated with MEN 2A or MEN 2B by contrast have been reported in younger patients, including children. They are also common in children as well. So, clinically, in the sporadic cases, the medullary carcinoma manifests most often as a mass in neck, sometimes associated with compression effects such as dysphagia or hoarseness. And in some instances, the initial manifestations are caused by secretion of a peptide hormone, for example, diarrhea caused by secretion of vasoactive intestinal peptide or VIP. Screening of the patient's relative for elevated calcitonin levels or RET mutations permit early detection of tumors in familial cases. So, all members of MEN2 carry these RET mutations, and they are usually offered prophylactic thyroidectomy to preempt the development of the medullary carcinomas. And often the only histologic finding in the resected thyroid of these asymptomatic carrier is the presence of C-cell hyperplasia or small micromedullary carcinomas less than 1 centimeter of size. Recently, it has been shown that specific RET mutations correlate with an aggressive behavior in medullary carcinomas. Now we will discuss about the morphology of the medullary carcinomas. So, medullary carcinoma may arise as a solitary nodule or may manifest as multiple lesions involving both lobes of the thyroid. Multicentricity is particularly common in familial cases. So, they are multicentric, meaning that there will be a lot of zones through which it can appear, and larger lesions often contain areas of necrosis and hemorrhage and may extend through the capsule of the thyroid. On microscopic examination, medullary carcinomas are composed of polygonal to spindle shaped cells just like smooth muscles, which may form nests, trabeculae, or even follicles. Amyloid deposits derived from altered calcitonin molecules are present in the adjacent stroma in many cases, and this is the hallmark feature of the medullary thyroid carcinoma that there will be amyloid deposition seen as pink structure on histopathology, and they are the distinctive features of the medullary thyroid cancer. Calcitonin is readily demonstrable both within the cytoplasm of the tumor cells and in the stromal amyloid by immunohistochemical methods. Electron microscopy reveals variable numbers of intracytoplasmic membrane-bound electron-dense granules. And one of the peculiar features of familial medullary carcinomas is the presence of multicentric C-cell hyperplasia in the surrounding thyroid neoparenchyma. And it's a feature usually absent in the sporadic lesions. So how you will differentiate familial versus sporadic lesions of the medullary carcinoma is the presence of multicentric C-cell hyperplasia in the familial medullary carcinomas, and in the sporadic lesions they will not be present. And foci of C-cell hyperplasia are believed to represent the precursor lesion from which medullary carcinoma may arise. So let us briefly recap our whole podcast so that we should just get to know that what we have studied so far in this podcast. The first point is that most thyroid neoplasm manifest as solitary thyroid nodules, but only 1% of all thyroid nodules are neoplastic. Follicular adenomas are the most common benign neoplasm, while papillary carcinoma is the most common malignancy. Multiple genetic pathways are involved in the thyroid carcinogenesis. Some of the genetic abnormalities that are fairly unique to thyroid cancers include PAX8/PPARG fusion in follicular carcinoma, chromosomal rearrangements involving RET oncogenes in papillary cancers, and mutations of RET in medullary carcinoma. So, follicular carcinoma includes PAX8/PPARG fusion. Papillary cancers include chromosomal rearrangements involving the RET oncogenes, and in medullary carcinoma there will also be mutations of the RET genes. Follicular adenomas and carcinoma both are composed of well-differentiated follicular epithelial cells, and follicular carcinomas are distinguished by evidence of capsular and or vascular invasion. Papillary carcinomas are recognized based on nuclear features. So that's important, that even though the papillary structure isn't present, still it will be recognized on the basis of the nuclear features. And what was that? We have discussed the story of the little orphan Annie, that how her eyes were optically clear. So similarly, papillary carcinoma also include that optically clear ground glass nuclei, including pseudo inclusions. Even in the absence of papillae, you will recognize based upon its nuclear features. And these neoplasms typically metastasize by the way of lymphatics, but the prognosis is excellent. Anaplastic carcinomas are thought to arise by dedifferentiation of more differentiated neoplasms, and they are highly aggressive, uniformly lethal tumors. And medullary carcinomas are non-epithelial neoplasms arising from the parafollicular C cells and can occur in either sporadic or familial settings. Multicentricity and C-cell hyperplasias are features of familial cases. That's the important thing. Multicentricity and C-cell hyperplasia are features of familial cases, and amyloid deposits are characteristic histological findings in the medullary thyroid carcinoma. And this concludes our podcast for today. Thank you. For further questioning related to the topic, feel free to email me at shafirehman@hotmail.com.